And we'll start as we usually do with introductions from the committee and then review the minutes before heading to the agenda. Let's start maybe with to my right, and then we'll go around.
All right.
The staff and the committee.
I'm not on the committee
Yeah.
specifically. I'm Christina Schultz. I also go by Chris. I'm the lead data analyst for the.
Hi, Michelle Goncalo, the opioid finance manager at OHHS.
Hey, everybody, Mike O'Neill. I'm the Director of Peer Services for Providence Center.
Sean Lacey, Representative, Washington County.
Phil Chin, or down Department of Health.
Rich LeClaire. James Mark Donnelly, I'm the Fire Chief of the City's Report, and I represent Newport County.
Good afternoon, Katie Hampton, and
Hey everyone, Alex McAdoo, for Brown School of Public Health. Excuse me, good afternoon, Patricia Reeves, Bristol County Representative.
Representative Paul, House Designee.
Jeffrey Braun, Chief in West Warwick, and I'm the Kent County Representative.
And I'm Julie Hamel, I'm the State Court Administrator, and I serve as the Chief Justice's designee along with Magistrate Valentino, who is not here today, so kind of tag teaming on that.
I'm Julia Harvey from the Office of the Attorney General. And I guess I'll just take a moment to say briefly that I'm actually going to be transitioning out of my role at the Attorney General's office. And so this is my last meeting with you all, and just want to say it's been a pleasure working with you. Thank you so much. And my colleague Lee Staley is here from our healthcare unit, who along with the D. Goldstein will continue to participate.
Thanks, Julia, for joining us, and all the luck in your new role. I'm so excited. Thanks. So thank you. And we'll go to maybe Karen and then Kathy.
hi, my name is Karen Flora. I work at EOHHS, and I am the program manager of the opioid settlement program.
Kathy Schultz, the Director of the Governor's Overdose Task Force.
Zilma Masufi, the Interdepartmental Overdose Project Coordinator.
And I am Brandon Marshall. I'm the chair of the Opioid Settlement Advisory Committee and professor of epidemiology at Brown. So we will get underway first with a review and approval of the minutes from our June meeting. Can I get a motion to approve the minutes unless there are any amendments?
So moved.
And second? Second. All in favor of approving the minutes, say aye.
Aye.
Any nays, abstentions? That motion passes unanimously. Okay, and those minutes are in your packet in case you're interested in reviewing them. So let's go to the meeting agenda. We've got a very busy and full meeting for you this afternoon. The aim of today's meeting is to give you the necessary information needed to vote on next month on the FY 2028 allocations. So we're going to start with an overview of the state's progress in addressing the overdose crisis. We'll hear from Chris on that. And then the bulk of today's agenda is going to focus on sections 4 and 5 on the slide. We'll be picking up where we left off last meeting with an update on the financials. I'll provide a high-level overview, and then Michelle will go into more details. And then we're going to move into a discussion of the proposed allocations today, which is very exciting. I'll orient the committee with our principles, our guiding frameworks, and then Kathy will share a proposal for you for comment and feedback. We'll then hear from members of the public as well. As a reminder, though, the vote on these allocations is next month in August. We just want to get a head start on that discussion, get feedback from you about additional information you may need for the vote, et cetera, changes before that meeting. So that's the plan for this afternoon. Okay, go to the next slide. So we'll move on. So first up, we'll hear from Chris Schultz. She's the UHHS Overdose Data Analytics Team Lead, who's going to lead us through what we call the Overdose Data Council scorecard and metrics that are used to track the state's overdose response.
All right.
Take it away, Chris.
So much. So as the lead data analyst for the task force, I also chair or co-chair the Overdose Data Council, affectionately known as the ODC. And so basically with the ODC, we develop and track a series of metrics. We engage the community just to see what trends are going on. We use the ODC basically to monitor. So as Brandon just said, we will be going over, it's a high level overview of the scorecard that we have developed. And I just want to point out that these are the core indicators that we have, we've identified for each of our pillars in the strategic plan. Again, core indicators, you're tracking way more than what you're about to see today. So I just want to keep that in mind. Okay. Yeah. And so as the Overdose Data Council lead, I help to monitor progress across those metrics and across those pillars. And then if there are any opportunities or areas that we need to pay attention to, we act accordingly. Okay, so a few of you, if not most, have probably seen something similar to this presentation because I presented it last year. There are some refinements, some updates to the metrics. So those of you who've seen it, there's going to be some new updates, but for those who have never seen it, it's going to be totally new to you. And I just want to point out, this is not a scorecard that was developed in isolation. This is a collaborative effort that we have an iterative process for. So basically, we get feedback from agency leadership, the smaller overdose data council, which is primarily state data reps, the larger overdose data council, which is state and community reps. And then we have, depending on the pillar, the context of the metric, we visit work groups. So it's a prevention metric or the prevention work group where we get feedback. And so on and so forth, because we want to have diverse perspectives and we want to identify what those priorities are at the community level as well. That said, this is a living scorecard, what we call a living scorecard. So if there's anything that comes up in trends, what we do, like emerging trends, anything evolves, scorecard evolves. So we act accordingly to whatever trends we see. And lastly, before we kind of go into the nitty gritty of things, I do want to point out a couple of caveats. Again, one, more metrics we're tracking behind the scenes, more, high level overview like you'll see today, but also program level metrics as well. And then second, and it's typically the most important point I like to make, is that correlation does not equal causation. Very often we get asked, what is specifically leading to the reduction in fatal overdoses? We can't just point out one. It's a collective effort across the pillars that are contributing to the reduction that we've seen over the past few years. I think with that, thank you. Okay, so before we get into each of the strategies and those metrics, I just want to point out that this is something you're going to see. We're going to see, for some, not all, we're still in progress of developing targets and identifying our progress, but for status, for a yellow arrow, you'll see the indicator is progressing as planned. We are actively monitoring data and developing trends. See a green check mark, that means we're on track. We're meeting expectations and remaining consistent with the projected outcomes. And then for a red X, which you actually aren't going to see, which is great, that would mean that the indicator is not progressing as intended and that we need to pay closer attention and take corrective action. So I think that said, on to the next slide. Thank you. Okay, first off, I want to go over the overall strategies. And with these two metrics, we are tracking both accidental drug-related overdose fatalities, and we are also looking at non-fatal overdoses. As most, if not all of you know, we've had a significant reduction in fatalities in 20 years. We have superseded our 2030 target as of 2025. We're going to go into that in a second. And then we also have our non-fatal overdoses that we are tracking. The reason why it's under review is RIDO has developed a new system. I believe they presented it here before. It's the Essence system. And so it's a more updated version of what they had for monitoring non-fatal overdoses. It was implemented, I think, January 1st of this year. So we're still waiting on more data to develop baseline and to, from then on, see if we're, develop target and see how we're doing. Next, please. Okay. So again, this is going to be a high level overview. You're not going to see specific data points for each of the metrics. That would be a lot. So I just want to delve into this graph, which I think most of you have probably seen. Again, just reiterating that we've had a significant reduction in fatalities. Since 2022, we've seen a 50% reduction. And what I take from that is we need to celebrate it, but we also need to keep in mind that 219 deaths, well, one death is one too many. And we just need to make sure we're maintaining our progress and sustaining our efforts. Next slide, please. Okay. Now we're going to get into each of the pillars. So first off, we have our prevention strategies. This is actually a pillar we're currently working to update the metrics for. So by next year, you'll probably see a couple of different metrics on this slide. For now, our primary metric is to increase the number of schools with Rhode Island student assistance counselors. So those are counselors who are trained to prevent substance use and improve mental health. The thing here with the 2030 target, you're going to see an NA, is over time, the number of schools changes. So we're still working to identify whether it's feasible to create a target. That's why you see that there. But we have been sustaining the number. And then for secondary, we have sustained the number of opioid naive patients receiving an opioid prescription. And we're on target there. We haven't seen any serious increases in those individuals receiving opioids. And then we always like to apply an equity lens. So we have 2 equity metrics. We have increased the diversity of the RISAS workforce. And then we have assessed potential racial or ethnic differences among students receiving said services. We actually just got this data through BHDDH. So this is something that we need to work as ODC needs to work through to identify targets, what's feasible, et cetera. All right, next slide. Next, we have harm reduction and rescue strategies. So our primary metric here is to increase the number of naloxone kits distributed in the community each year. Technically, each year we have a 50,000 minimum naloxone kits that we intend to distribute, and we basically meet that every single year and have for the past few years. So we're right on track there. And then our other 2 primary metrics are to increase the number of in-person harm reduction encounters each year, as well as the number of unique individuals served. And we've been on track there as well. Again, equity lens, we want to increase the number of naloxone kits distributed across racial and ethnic groups. And then we also want to increase the rate of encounters across racial and ethnic groups. Again, we're still working. It's a little more challenging to identify targets for these types of metrics. So we're working through them. And by next year, hopefully we'll have some updates there. Next slide, please. Okay. Treatment strategies. This is what I call our behemoth pillar because we have a lot for metrics for treatment. Our primary metric is to increase the rate of people connected to treatment within 6 months of an overdose. This data has finally been completed, this analysis I'm very excited about. And so by our semi-annual report, I think we'll probably have that in September. So we'll have some updated data there for you. And then our secondary metrics, we have maintained the rate of people receiving sustained buprenorphine treatment, as well as methadone treatment. And then we want to increase the cumulative number of individuals who are receiving either buprenorphine or methadone. We're monitoring. We're not seeing any causes for concern, but we're still in progress. So we have some work to do there. Next slide, please. All right, and then our last 2, we have one more secondary metric, which is to increase the number of healthcare professionals prescribing buprenorphine each year. Due to changes in policy, this number has increased. And then for our equity metric it's tied into that primary metric, which we just got the data for. It's increasing the rate of people connected to treatment within 6 months of an overdose and breaking that down by race and ethnicity. All right, one more. Okay, our last one is recovery strategies. This is another similar to prevention. It's another pillar that we are working to update this year. So that's one of our goals. So next year, again, you might see some changes here. But currently we have for our primary metric is to increase the number of certified peer recovery specialists and community health workers. We've done so over the past few years. So we're on track there. Our secondary metric is to increase the percentage of people leaving a certified recovery house for stable housing. We're currently under review there. We see some changes in method and changes in trends, but we only have several years of data for this, so we're still monitoring. And then lastly, we have our equity metrics, which is to increase the racial, ethnic, and linguistic breakdown or diversity of CPRs and CPRSs and CHWs. Lastly, in line with that secondary metric, we want to assess potential disparities among racial and ethnic subgroups concerning the percentage of people leaving a certified recovery house for other stable housing. Okay, and I think that leads us to the end. And I just want to point out, and thank you for pointing this out, if anybody's interested in coming to the Overdose Data Council, if you're not already joining, we're going to share an email somehow. But
So, yeah. So the Overdose Data Council is a task force work group. It's been around since the beginning of the Governor's Overdose Task Force. So if anybody is interested, please feel free to reach out. Our wonderful Carol Stone, it's behind the scenes of this as we speak right now. And Carol can add you to any of those listservs to get more information. We also have all of our presentations from the Governor's Overdose Task Force on Prevent Overdose RI. If you go to Task Force, there is an archive of all presentations. And as Chris mentioned, you would see more information around, such as the non-fatal overdose surveillance system that was just presented there last month. Every January or December or January, it's usually January, the Overdose Data Council in all of our state agencies. I want to also add that the state agencies, the data that Chris is presenting right now, just as I do as the task force director or here as the OHHS staff, we are collecting all this data with our state agencies who are actually the stewards of that data. So I want to thank the Department of Health, HPH, even DLT, no, the certification. And the Department of Corrections for continuing to work with us. We also work with DCYF and many other state agencies in the Overdose Data Council. So please join us. It's really interesting and we want to really bring the community voice to the table.
Yeah, we have some time for questions. Alex and then Julie.
Okay, so now just thank you so much for sharing these important data and metrics. This is fabulous presentation. I just have a super quick question just about under treatment strategies, the final metric. I was curious whether, the rate of connecting folks to treatment, is this, following an overdose, is this opioid and overdoses only or also?
That's a great question. So we used to have a metric that was looking only at opioids, but since trends are not just,
Yeah.
so we developed an overdose data council if they experience an overdose from any substance and then connected to any type of treatment. So it's not specific to MOUD because that's what it used to be.
Yeah.
And so that's where we've made that change.
Fabulous.
Yeah.
We'll check that. That's awesome. Thank you.
You're more than welcome to join the Overdose Data Council.
Julie, go ahead.
Thank you. On slide 7, so given the drop in overdose deaths, does that mean that the council will recalibrate the targets?
That's a great question. We've had this conversation behind the scenes a little bit. I was just gonna say, we're gonna bring it to Overdose Data Council and see
So
everyone's perspective.
I think, do you want to speak on behalf of the task force or do you have another question? If you want to.
That was my exact question.
Okay.
I'm going to ask one follow-up question on that too, which is just as we think about this, I think we initially set that 30% decrease just as a realistic benchmark. We really knocked that out of the park. So congrats to everyone in the community. I think this is almost a question for Dr. Marshall, but we should think about what is a reasonable target to get down to.
So, yeah.
We struggle with this in HIV because it's like, it's not really probably realistic to have 0 new HIV diagnoses in Rhode Island. It's probably not realistic to have 0 overdose deaths, unfortunately. I mean, we say that and we can strive for that, but we should have a realistic goal of what are we actually going for? And I think now it's the time. We set that 30%.
Yeah.
What is, we want to get to 5 or 10?
So Dr. Marshall, please feel free to
Sure,
answer, but I wanted to just say that, yes, to everything that Chris said, the Overdose Data Council will have that conversation about that, but it actually ultimately, that's why I asked Dr. Chan, because he's leadership for the Governor's Overdose Task Force along with Director Leclerc. And then also Director Larkin is one of our other co-chairs. I know that the Assistant Secretary, I think, is listening in. She's also leadership. And then we have a community co-chair. So we will use, like we did in developing this target in the first place, that same process through the task force, through our state agencies, through data, and determine whether we are going to change that goal. But that's why it's so important that we're looking at this type of metrics at a more granular level to make those types of decisions. But yes, to everything you said, and Dr.
Yeah,
Marshall, please.
Sure. Yeah, it's such a good question, Dr. Chan. My own personal opinion is that, so we've gone back to where we were in 2012, which is outstanding, right? So we've turned back the clock well more than a decade, but we still remain well above other high income countries when you look at global comparisons. So that might be one place to look at a benchmark. What do other higher income countries achieve in terms of annual overdose rates each year? That might give us some insights into what, is that floor in places that have not had this explosive opioid overdose crisis that we observed in the US. So much more, I think, needs to happen on that, but there's some places we can look to, I think, for benchmarks that might help us set a realistic goal, because I agree with that.
Yeah, and we will be, that will be a conversation. We're gonna wait until the end of the year. And the Overdose Data Council will present in January at the task force. And that's when we'll sort of talk to the task force. And we really want to make sure we're intentional about getting the community input up into this. But I think what this tells us is that whatever we're doing right, right? And it's a celebration because there's a lot more people that did not lose their lives. And, you know, but there's still much more. Dr. Chan actually did a Boston Globe, and it was sort of perfect. And I'm sure you heard that from the community as well. And that was, we're doing great, but we need to sustain it now.
Paul, did you have a question?
Yeah, I just had one thing, only because the equity. Is it because it's new, we added it?
Depending on the metric, So I think another big barrier, but conversation we have to have is how to identify specific targets. It's difficult to just to appoint a target for each racial ethnic group. And so that's where gets a little jumbled, but
Well,
it's one of our.
Reach out and ask people.
Yeah.
These are some of the questions we.
Yeah.
Want some answers.
Right. Yeah, I mean, we're tracking them. You can see the data, but we don't have specific targets yet. That's the only thing.
Questions? Yes, Director.
And Christine, I'm happy to see there are no symbols for off track.
Oh, I know. Yeah.
So that's always good. I had a specific question. I'll just use that as an example. The peer specialist indicates that our target is 725 and we're on track. Does that mean we're on track for reaching 725 or on track for an annual target? Or how does one interpret that?
It's mostly we're on track to, based on the counts that we've seen for, I think it's through 2024. We're still waiting on 25 data, but we've seen significant increases. So it's that we're on track to meet that goal in 2030.
On track for some, do we have annual targets?
We don't have annual targets, no. We've set with 2030 in line with how we've set our fatality goal.
But yeah, but now you go to measure each year. What is the measure for that one in particular? For the peer specialist?
For the peer specialist, should we not see?
It's the one that says peer specialist and.
No, I just meant did you want just CPRSs or?
Sorry.
I know, I wasn't sure if you wanted just the CPRSs without the CHWs. No, we don't set an annual target. We just, as a group.
What's the actual?
Or we don't set any equity, sorry.
How many do we have that?
Oh, I have to check. Hold on. I gotta go into my data.
Yeah, there's actually a portal of, I believe it has it on there. That Candace had presented last month. I think she might have presented that data. And she actually looked at, we have a workforce portal. And I know that CPRSs and community health workers are actually in that portal.
Yeah, in 2024, we had about 700, so we're getting there.
So the 700.
So we're almost there. That's basically why we're on track. Yeah.
Okay. All right, well, thank you again, Chris. We can circulate the information about the Overdose Data Council for anyone who's interested. I'm going to move us into our first public comment. Many members of the public attending today, but I did want to open up the floor in a moment. We'll be sure to have lots of time for public comment after the second part of the meeting where we really see the meat and the proposed allocations. Also, this is when I like to take the opportunity to update the committee on whether we received any inquiries through the public email address that is monitored, and we did not receive any responses in the last month. All right, so we can move to public comment. Are there any members of the public who would like to say anything? Yeah,
So
go ahead. Yes, the floor is yours.
As a public member, I am representing the Addiction Recovery Institute as their community and song. So it's my first time in attendance. Happy to see smoke on your faces. Thank you.
Welcome.
Awesome.
Thanks for being here.
Thank you for
for having me.
Appreciate it. And anything on Teams, Kathy?
I do not see anybody's hand up. If anybody is interested in speaking to public comment, please raise your hand. Or walk me up. We had, thank you, Monica just wanted me to repeat, Ryan from ARI, Access Recovery Institute. Is that what?
Addiction recovery.
Addiction Recovery Institute introduced himself. He will be also getting connected to the task force and join some of the work groups.
Okay. We may have more public comment, but we show a lot more data and recommendations. So let's move into that part of the presentation. Thanks, Sil. So this is the primary content of today's meeting. I'm going to provide the committee with a higher level overview of where we are in terms of the budget and financials, and then I'll hand it over to Michelle to provide a deeper dive. So get ready, we have lots of data for you. We'll stop frequently to answer any questions you have for us. Okay, if you go to slide 16, so there's a lot of terms that get thrown around. We'll see them today and we've seen them in past meetings. I just wanted to add this slide to level set everyone and go through some of the key terms that you'll hear throughout today's discussion. First, payments received refers to the fiscal year during which payments come into the state from parties that are privy to the settlement agreement. So that essentially means when a payment is received into the state's coffers, that you'll see in a moment. The second term that you'll see often are allocations. That refers to when you, as a committee, recommended specific allocations, and we do that by pillar, right? And that happens in a specific fiscal year. Once the committee recommends an allocation and those recommendations are accepted by the secretary, those are considered binding, right? And so then we can't move funding around across pillars without bringing that back to this committee for review. Some of the allocated funds that you recommend in each year remain unspent, and they then can carry forward into future fiscal years. This is a real benefit of the opioid settlement dollars. They're very flexible in this regard, right? Unlike many federal grants where you have to spend down by the end of a fiscal year, we have a lot of flexibility to move funding forward in time. So we use the term unspent to refer to that process. And then Michelle and many others, I assume, have to create a budget each year, which is the sum of the allocations you vote on and any unspent. And those together create a budget for a specific year. So those are the terms you're going to see floating around. Go to the next slide, Sil. So I want to orient us first to this slide, which is what I call the decay curve. This is essentially the estimated fiscal years during which the state will receive payments from settlements. That's shown in light green, right? So there's a couple things that I want to draw your attention to here. We received a large bolus of funds from these parties, opioid manufacturers, distributors, large chain pharmacies in 2023, 2024, and then it goes down, what I call a decay, right? And that is under the terms of the agreement. There's a few really important things to keep in mind here is that it's hard to know exactly when payments are received. We've talked about this before, so these are expected, right? Sometimes settlements come in earlier than expected, sometimes later, so there is some change. Sometimes there are unexpected small settlements which get added into the coffer. This also does not include upcoming new settlements, for example, Purdue, which is a big one. We've talked about that before. We expect the Purdue settlement to be finalized this fiscal year. And as a reminder, the Purdue settlement is all up front, right? So that will create a huge spike on probably fiscal year 2027 when that all comes in as a single lump sum payment. And then there are also placeholders that work sort of under the scene when we expect a payment to come in and then require some modification when they actually do, depending on the fiscal year in which they're received. So those are the light green bars for you. The dark green bars show the actual spend rate. So the invoices that are processed and paid to organizations that have received the opioid settlement funding across the state. So you can see the spending ramp up, right? We estimate so far in this past fiscal year, which is fiscal year 2026, that the spending is at 13.7 million. Now, Michelle wants me to remind you that that is up to July 8th. That number will still increase more as additional invoices are processed and finalized, but that's where we are as of several weeks ago. So that's something we want to draw your attention to as a committee, is that we are now in a place where the spending is above what we expect to receive each year. Now, I would not argue that it's a crisis, right? We have a lot of unspent funds and we have new settlements coming in, particularly Purdue. So we have flexibility, but it's something we need to think about, right? In terms of sustainability, that we're now at this steady state where spending in general is in excess of what we currently expect to receive each year. I'll look at my notes to see if I missed anything. I think that is it. Kathy, before I move on to the next slide, was there anything you wanted to mention there? Great, okay. I'll do the next slide and then I can stop for questions. You can go to slide 18 still. So these are similar data just presented in a slightly different way that I think is more useful for you as a committee member, as committee members. So the dark green bars are the same. That is the actual spend rate from the past 4 fiscal years. The light green bars now are different. Those are the actual values that you as a committee recommended in terms of allocations each fiscal year, right? So the first allocation in fiscal year 2023 was an allocation of $20 million. So those light green bars differ, right? When we vote and allocate funding is different than when we actually receive funding from these parties that are privy to the agreement. So that's why there's quite a lot of difference there in terms of these 2 slides. So that is expected. What's important to know is that in general, the amount that the state is receiving and the amount that you're allocating over time is matching. So Michelle, before the meeting, you gave the numbers to me. So correct me if I'm wrong, but so far to the past fiscal year, we've received $72.9 million in payments. And this committee has allocated $69.4 million. So we're on track, right? As we are receiving funding, we are asking you to allocate it, and that is basically keeping. So last year, we allocated $10 million as a committee. This year, we're going to be allocating fiscal year 2028, which Kathy will get to later today, and we are also asking you to allocate another $10 million. The last thing I'll say, just as a reminder, I should have started with this, I get confused all the time, is what is a fiscal year, right? So it's just helpful to remember that it goes from July 1st to June 30th. That's the state fiscal year, which is different than the federal fiscal year. And it ends June 30th, and that denotes the year we're in. So we just started fiscal year 2027. We're in that now, and it ends June 30th, 2027. We will be talking about allocations for fiscal year 2028 later in the meeting. Okay. Any questions so far? And then I'll hand it over to Michelle, who's even more detail for you. Julia, yes.
This is a clarifying question that I think I ask every time, so apologies. The allocated number, does that include any rollover that was unspent in previous years, or is that additive to?
It's additive to. So you'll see that in a subsequent slide, that basically the unspent gets added to that fiscal year's allocation. Now, the allocation of the unspent stays the same. We are not permitted to change the allocations across pillars, right? So any money that's unspent, the breakdown remains the same as to what that was allocated. And you'll see that on the prior slide. You might be able to see that breakdown. Yeah. Yes, Director.
We track obligated.
Yes.
Yes, we do.
So is that a substantial number that influences how we would allocate?
So I can answer that.
Please do, Kathy.
The agencies across the agencies that are receiving funding and stewards of funding that goes across, so it's BHTDH, RIDO, and EOHHS. I shared the encumbered report. I call it encumbered, which is obligated, which means it's in contract. And that was shared in the last meeting. So that was 68 million approximately, but because even it was by agency. So that slide deck. I can find it for you and give it to you again so you can see it. That broke it down and that would be what's obligated. So, but in addition, because I figured you would ask that question, Director, and not in a bad way, because it's important. This committee has asked that in the past, I also am working with the agencies, and you'll see a little bit about how we make financial strategic decisions on how we come up with these proposals in the first place. The agencies are also updating that obligated, again, for us. We've all agreed we're gonna do it quarterly, because last year we kind of did it all at the last minute to present to you. So we're doing it on a quarterly basis. And the deadline happened. I just need to look at it. And I should be able to give you that information by pillar next month. But again, it's estimates and it's based on what the agencies provide to us. It's really important, and we're going to get into this with the OMB. It's really important to remember that this settlement, we have to look at all of the funding. We can't just look at just settlement, because that's only a very small it's a small percentage actually from the bigger picture. So that's what we're waiting for, is to get that information from the agencies so we can look at how it's braided with stewardship and federal funding as well.
Did you say 68 million was obligated?
I think it was 61 million is what I presented last month. And it's about 61 million was obligated in contract. But what I had said last month when I presented that is because it was before state fiscal year ended, there were contract renewals happening. So that's why I asked the agencies to update it again, because I knew it wasn't going to be completely accurate. Because I know for us, we're adding more money to contracts that end on state fiscal year.
I could recommend maybe in the future having some of that information here.
Sure.
It's germane to what's spent, what's been allocated, what's gonna be allocated.
Yeah, that's great. We can include that next month. And it's such a great point, Director, because just because you'll see large numbers that are unspent doesn't mean it's not obligated, right? So to Kathy's point, the vast majority of funding is obligated. It's in contract. It just might not be spent yet. So an example would be, say, a facility that receives some money to build out some new residential beds. That's obligated for that bill, but they just haven't invoiced the state yet. So I see your point, and we can include that information next meeting. Yeah, we didn't want to throw so many different ways of looking at the money today, but it is really important.
Thank you.
Makes it easier.
And that's what we want to do, is make it as easy as
Exactly.
possible.
Yep.
Yeah. Any other questions on this before we get into more detail by pillar, actually, and the budget?
Sorry,
Yes,
just
Dr.
one question that follows up on Julia's comment. So if you look at 2023 with the 20 million that was allocated and 4.2 that was spent, so there's, like 16 million there that was not. So does that carry forward to future years, or where is that in this graph, or is it not?
You know what's really great is that Michelle is actually going to present the budgets, and you're going to see it, and you're going to also see it visually in some of the next slides.
Okay.
It ends up going into the budget as unspent, so because it carries forward.
Yeah.
Okay.
Yeah. Great. Okay, let's turn it over to Michelle. Go to the next slide, and we'll have lots more time for questions as well. So take it away, Michelle. Yeah.
Thank you, Brandon. And I just wanted to add, just from the previous slide too. So yes, as Brandon had mentioned, so spent for FY26 was through 7/8. So this will be updated next month as well. Even though we are still currently in the process of closing FY26, it will still not be closed next month. So it's a process that takes months on. DOA Accounts of Control has their adjustment period, and then there's the audit period. So there's always adjustments that take place for months out. So, but we will get you the best estimate possible next month. So the next slide, so this is the one that everyone is asking, where it provides more of the detail of what is spent by pillar. And there's also another slide. I was just curious, can we look at that other one on 19 for 1 second? Yes, here we go. So on this slide here, so everything that every year on the committee votes on allocation. So as you know, the 20 million is the first one, the 10.3, and so on for every fiscal year. So we are currently working on the 10 million. And anything that is unspent gets carried forward to the next fiscal year. That becomes the budget. So when that year is unspent again, it just keeps carrying forward year after year after year. So this slide here, if you look at column state fiscal year 25 estimated unspent. This is the unspent from 23, 24, and it's going into 25. So this is right now the unspent for FY 25. We were at 23 million and it's listed per pillar here. You voted on FY 26 allocations for the 20,700,000. That added together creates our budget now for FY 26. So when we started July 1 of 2025 for FY 26, we were at 43 million and change. Then we have an estimate this year of 13 million, a little over 13 million spent and counting. Whatever that number, so technically would be the 43 less whatever is spent, let's just say the 13 million, plus the allocations for FY 27 of the 10 million, and that's where we just keep adding it every year, our budget year after year. So right now, with an estimate of the 13 million spent, we would start FY 27 with $29 million. And that does not include the 27 allocation. So then it would just keep, the formula would just keep going.
Are organizations signing multi-year contracts? Is that accounted for in, so in the unspent, is some of that actually obligated?
Yes.
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 I know for I can speak for EOHHS having contracts. I actually intentionally tried to do multi-year contracts because of the fact that we know that this funding goes down. So what I try to do is sort of spread it out for a couple of years because it's better for the organizations and it's more helpful for the organizations because 1 year contracts and you hire staff, say, and then if you don't know for sure if you have funding for the next year, it makes it very difficult for agencies.
Absolutely.
It's not federal funding. You can't always do that. That's the difference. And that's why this is important and it's flexible, especially for programs that are not Medicaid reimbursable services or not being funded by other federal grants.
And then one thing I'll add too to my earlier point that might have been confusing is that the unspent tracks with how this committee allocated that money. And it can't be changed. So for example, the 800,000 that was unspent in racial equity, just because it's unspent doesn't mean Michelle or Kathy can like take that and allocate it to some other pillar. At some point, you recommended that funding for racial equity, so that's where it stays and it keeps carrying forward within that strategic pillar, if that makes sense.
And of that $874,000, I don't know exactly how much off the top of my head, but some of that is actually obligated or in contract as we speak. But it's just not spent yet.
Questions for Michelle?
Sorry, but the majority is obligated for the director's question.
Yes.
61 million as of last month, I presented that by agency. 61 million was obligated, which encumbered, meaning in contract, or it could be for staffing. There was a note on that. And then I am waiting for more information from the state agencies because the same with Michelle is fiscal close. So therefore you add more funding to many of the contracts because now you have access to the FY 27 funds.
Okay. Answer. There's 29 million, the budget. How do we get 61 million?
If you
Total years
total years, yes,
from the start, FY 23 to 26.
total years. The total years equals 69 million, correct, Michelle?
Correct.
So therefore 61 million of that 69 million has been encumbered. Some of them are no longer contracts, say, because they were already spent.
So you
Does that make sense?
encumbered, it actually been paid out. Well,
Some of it, yes, it includes the spend, but some of it hasn't been paid out. It's just in contract and it's actively spent.
And the 69 million is your voted allocation per fiscal year. So we have FY 23 to 26. That totals a little over 69 million.
Jill, can I ask you a question then? So I think what I'm hearing, because approximately, I'm using approximates here, 69 has been allocated and 61 of that has been obligated. Would it be correct? There's 8 million of that has not been obligated. Would be correct to infer that approximately 20 or 21 million of that 29 million number is obligated?
Could be correct of saying that, yes,
Okay.
because we do not have, all of the obligations is not in contract obligated. encumbered, it all falls under that word. So yes, there is,
But we're getting updates right now.
Correct.
And because I got the information so that we would have it for last month's meeting. It was before fiscal close.
Yeah.
And usually that's when you do contract modifications, you add more funding. Because we didn't have access to the FY 27 funds at that time yet, because it wasn't fiscal year 27. The allocations you already voted on. So there are contracts that have been.
we anticipate that 61 obligated to be a lot higher as soon as that's updated, hopefully next month.
Got it.
I think what would be helpful, and maybe just to say it explicitly, and I apologize if I'm repeating, just because sometimes the numbers, you make your head spin. But I think what would be helpful would be to see for each category here for the unobligated, right? Because, for example, treatment category for, 7.3 million, it sounds like a lot of that's obligated. So I think for us to accurately have a sense of like what's going to be in each pillar or what we should recommend for fiscal year 27, we should have a random, an estimate of the unobligated about how much will carry forward. Because if all 7 million carries forward, that I think drastically affect how we think about allocating versus if most of that's obligated and only 100,000 carries forward, then does that make sense? Like that?
Yeah, I presented this last year and I actually was in the process of having it ready for you all, but I'm waiting for the agencies to give me those numbers. And so it will be by obligated, if that's okay, the total obligated. That's the way we did it last year. Will that work for you all?
So
It's easier for.
But is that by pillar?
Yes.
Got it.
Yeah.
Okay.
Yeah.
And I'll also, where I've asked the agencies to also give stewardship and then an estimate of federal funding too. So that's how I presented it last year. So we'll present the same this year, next month.
I'm not saying anything.
You're with
Time around.
Dr. Chan and I had a talk about it last year. This time,
I have my lucky Red Sox on.
Other questions? We have one more slide actually for Michelle to present as well that just looks at the data in a different way. Maybe let's go to that one and then.
Sure,
we have
let's go to the
more
next
time.
slide.
Yeah.
So here on this slide, it's representing the same information. It's telling you the total allocated 69 million, estimated spent 40 million, and this is cumulative. So basically from FY 23 through FY 26, which is an estimate data of spent of 7/8/26. So this is just breaking it down per pillar so you can see what was obligated. Just looking at the last one, just as an example. So we have recovery. So obligated 8.6 million, and again, all years combined cumulative, and then spent the 4.7 million. So this is looking at data for all fiscal year thus far.
Sorry, one other question.
Yes.
So for those multi-year contracts, if an organization had a contract going into fiscal year 27, is that captured in, where's that captured?
so this is not showing you the obligated or the
Correct.
encumbered, it's only showing you the spent. So this is only through FY 26. The contract could, if it would only be, it's allocations and spent. So
Correct.
maybe you can explain.
Yes, allocation spent. So to your question, no, if it is obligated in FY 27, no, it is not reflected in this data. We're hoping the obligated piece that we'll update next month will show, and then you can see a difference per pillar.
Yeah, because that's the difference, right? That money is earmarked essentially for that contract that's
That's right.
ongoing.
That's-
So that will be shown in the obligated
Yes,
amount, percent. Yeah. Does that make sense? Dr. Chamet is not reflected here. Yeah.
Sorry, one other question
Yeah.
too, that came up last year as well. So it would also be helpful to know what percent or what programs we want to sustain, right? So there's some, so understand some organizations have multi-year contracts. So if we take like, for example, the safe injection site or some other programs that we probably want to sustain kind of long-term, it'd be helpful to know if that's already accounted for or if we need to allocate new money for that.
So when I go over the process, I think you'll see an answer to that, if you don't mind.
Sure.
Because we work with the agencies who are managing those contracts. So none of the decisions and the proposals are not, it's not in a vacuum. It's thinking about those things that are funded right now. And I also added sustain pilot. You can go in your packet.
Questions? Okay, lots to chew on. And we have more for you to chew on that fortunately though zooms out and looks at these data in terms of the broader total revenue for overdose and STD programming in the state. I really like this. I find it helpful. I hope you do too. So Kathy's going to walk through it in a moment. We enjoyed reading the report so much that we printed it out for all of you. So what you're about to see is available in a report that is public, that was published recently by the Office of Management and Budget. So we're just presenting a few slides, but all of the great details are available for you. The goal is really to get a better sense of how opioid settlement funding fits into the overall picture of spending in the state. So with that, I'll turn it over to Kathy to walk through, and then we can stop and have a discussion and answer questions. Want to go to the next slide still? Okay, take it away, Kathy. Yeah.
So as Dr. Marshall said, you have a packet here, and it kind of tells you the process that was taken to come up with this report. This was a partnership with EOHS and led by the Office of Management and Budget. And we went to all of the agencies and agencies beyond the Department of Health and BHH, Department of Corrections. I mean, we went to the courts. So this has a lot of input to do basically a survey. It was a survey and it was really looking at all of the investments in substance use disorder in spending. Right? So this slide right here, it's literally what it says, which is that opioids, and just so you know, if you want to follow along, you can look at pages 11 and 12. Those are the ones that we're really highlighting here in that report. So basically, for the substance use disorder non-Medicaid programs for FY25, 2020, this is only 2025. We're hoping to do it for 2026, but we need to work with OP on that. Opioid settlement funded represented 24.5% of the total SUD programmatic funding, while federal funding and general revenue accounted for 68.8%. I think it's notable that the agencies reported that 53.7 million on non-Medicaid SUD programs in FY25. Approximately 45% of the non-Medicaid spending on SUD programs comes from federal funds, followed by opioid-related settlements at 24.5%, and general revenue at 21.7%. I just, because I've been in part of this in the background, last year we had a report from FY23 that we did with OMB, and it was a much lower percentage for settlement, but that would be because it was 23 was the first year we received settlements. So now the settlement amounts have gotten bigger, but if we do one next year, it might even actually be lower. And it'll, each year it's gonna replicate the revenue that's coming in is based on that settlement. And then the remaining 8.7 comes from other restricted receipts and other funds. So with that, we can go to the next slide. This slide doesn't have a lot of words, but it gives a lot of information. And also you can go to page 12, I think this one can be found. So as shown in this slide, federal funding accounts for more than half of the dollars spent on treatment programs. And I kind of broke it down in some bullets, and I'm going to say this verbally to you all. Treatment was 25% or 13.5 million of the non-Medicaid SUD spending, with half coming from federal funds. Recovery was 20% of the 10.5 million of the non-Medicaid SUD spending, with nearly 40% coming from federal funds. Prevention, 92% is federally funded, which is a total of approximately 8 million. Harm reduction, social determinants of health are primarily funded by restricted receipt accounts, either settlement, stewardship, or categorized as other. And I really wanted to kind of show you all this slide so that you can really take a look at, see the difference and you can see the key. I think everybody can see that. I know it might be a little small. I have to wear glasses now, everybody. I can't see at all when I'm looking at a piece of paper anymore. So, and if you really look at it, it really breaks it down for you to see the different buckets and what is sort of reliant on sustaining those programs and what's being used to sustain those programs. And the other note I wanted to just make is that Rhode Island Health and Human Services agencies operate most of the surveyed non-Medicaid programs. The BHDDH, the Department of Behavioral Health Care, Developmental Disabilities and Hospitals, I wouldn't be able to say that unless it was all written for me. Manages 36 programs with a combined budget of 23 million. The Department of Health manages 14 of the programs with a collective budget of 14.1 million. And EOHS operates 18 of the programs with a combined budget of 14 million. And together, these agencies account for approximately 71% of Rhode Island's total budgeted non-Medicaid SUD funding. So that might help you all understand why I always mention BHDDH and the Department of Health, because really they are the agencies that are mostly operating a lot of these programs. And you can go to the next slide. And Brandon, I can say this or you can
Go ahead, Beth.
it's up to you, and then I'm going to hand it back to it, Dr. Marshall, because in the research, and we can as much better. Opioid settlement fund supports a relatively small share, 24.5, as I said in one of the other slides, of the total non-Medicaid spending. Yet they're a crucial component of the state's overall response to the overdose crisis. Among non-Medicaid spending, the largest share of funding overall is directed towards treatment and recovery pillars, and federal funding varies significantly across the pillars. Fewer than 20% of the funding supports harm reduction and rescue pillars, while more than 90% supports the prevention pillar. Opioid settlement funds are used to boost investments in pillars that would otherwise be underfunded, particularly the harm reduction pillar. I also want to add to that, and this is, we all know this, we've talked about this here, I'm sure you've heard this, and you see this also on the news a lot, is that also harm reduction, we have received, I know that BHDDH and the Department of Health and EOHS, we've all received that their colleagues letters that have specifically said that you cannot use federal funding for harm reduction supports. So I just wanted to kind of put that out there so that you have all the information that you need.
So much, Kathy. So there's a lot more detail in this report, but we found those two graphs particularly helpful. I guess the only other note I'd make too is the report talks a lot more about Medicaid and the upcoming changes to Medicaid as a result of the Big Beautiful Bill Act. So that is in there as well. Medicaid is actually the largest share of overall spending, but for the purposes of today, we took Medicaid out of the equation, focused on non-Medicaid expenditures. Yeah, Julia.
That's actually related to another question I had while reading this, which is, I know that this is for FY25. And we've talked about this sort of generally as a group before, but do we have any information or insight as to how the other, and not even Medicaid, but the other like federal sources may be changing over the next couple of years, if at all, and just thinking how we might consider that?
So we did have my colleague at EOHS, James Rajat, join us at one point. We also, I don't remember, I know if you were, I think you were here. We also asked Regina LaBelle, who is a colleague, I'm a big fan of hers. Brandon is too, and I think Senator is now too. But Regina LaBelle, so she is an expert in policy from Georgetown, and we did ask her to join us and give us some kind of overview of what we can sort of expect. And we have what we call the HR1 advisory committee or advisory that was under an executive order that is working very closely with DHS and Medicaid to see how it could impact some of these programs. And we also have, and I'm not just trying to call you out, but we do have representation from the Department of Health and BHDDH. And I do know that there have been some significant grant considerations and cuts across some of the programs, especially, and they really, you know, it's hard because we can't really even predict what's going to happen from day to day. I hear from agencies, and we meet on a regular basis, that it's, you know, they'll kind of comb through the words in a contract or a grant that exists and then say, you need to send us additional information. You have 5 days to do it. So that's the kind of impacts that are happening to our agencies.
Yeah, Mike, and then I'll let the agency leads add as well if they'd like to.
I had a question. So if say there's funds that are earmarked for harm reduction already, right, that allocated, with the change in this current administration that, you know, it doesn't support the certain harm reduction supplies, whatever, can they still purchase that with that money that was?
This, for the settlement, yes.
Yeah.
Right, okay.
Yeah.
That's why we're.
Yeah. As far as I'm aware, the federal government has no purview over settlement funding. You do, and the state does. But my understanding is that the federal government really can't direct settlement funding whatsoever. Yeah.
Thank you.
Yeah. So it's yes, Director.
To partially answer your question, you get a lot of source funding, this is all federal money. And so that allocation is based upon a prevalence of certain instances in states. So as we do better, we'll get less money. Not, I don't know how much less, but that's probably a year and a half away. And there's carryover from 1 year to the other. So sometimes it depends how we do in terms of knowing what kind of allocation we get. At least it's sort of,
Yeah, so I'll say this overview is so incredibly valuable and helpful. Curious to go back just to the prior slide. I was curious about some information just to further contextualize these data. And I wonder if anyone's able to speak to like how we should interpret general revenue, that line. Let's say in the context of like, is it harm reduction and rescue or recovery? Would that be like donations to organizations that do that work? I was just curious how to interpret
General revenue?
Just state funds.
State funds.
Yeah.
Yeah.
Okay. General revenue. Right.
State general revenue.
Yeah.
Okay.
The tax base.
Got it. Oh,
Yeah.
okay. That's helpful. Thank you.
Yeah. So for example, to my knowledge, the MOUD program in the ACI is funded through general revenue. Is that right?
In part.
In part. Yeah. So
The
that.
other part is
Yeah.
stewardship.
Yeah.
There's also the small restricted receipt account stewardship, which is they're together. So when you see the gray, that includes stewardship. Thank you.
Yes.
The green, what was that one? What is?
It's a good question.
I had the same question.
I actually sent a Teams message. Maybe if I can
Yeah,
answer
like,
it.
what is the green? Yeah.
I sent a Teams message, so it must be,
Yeah.
because I don't know what restricted receipt accounts, if somebody else does, that's great. But I actually asked, what exactly is that restricted receipt?
Yeah, I didn't know.
Did we get an answer?
No.
No, we did not get an answer.
That's right. Red Sox are up
Anna-
1-0.
The assistant secretary actually has her hand up. Maybe
Okay.
she could answer that question or one of the questions. Hi, Anna. You're on
muted.
Can you hear me now?
Now we can.
Yes.
Okay. I was going to say I wasn't responding to this specific question, but in general, a restricted receipt account is just a different kind of accounting mechanism that the states use for funds that could come from any kind of source, and the difference that are non-federal, they are non-state. And so, for example, if you get a settlement fund, it's a restricted receipt account. The funds that we get from the insurance companies for vaccines, that's another restrict account. And so I don't know that green one, which source it is, but it just means that it's not federal and it's also not state general revenue. And it's a account that, because it's a restricted account, it exists as long as there is funding in that receipt, like, that state allocations, general revenue, they are for 1 year. Federal allocations, they are for the federal fiscal year, that whatever happens. The restricted accounts, they move from year to year as long as there are funding. So it could be, I don't know what's that source, but I was going to say that in general, and I'm glad someone mentioned, we're not reflecting the Medicaid funds, but we are also not reflecting in these analyses funding that's coming from commercial insurance and payments into the state. And that's important in the broad context of everything that we're discussing, because the more that those other funds support the traditional pillars that we have here, but then all of these other pillars that together really make us being the success story that we're seeing, they are not supported either by Medicaid or by commercial insurance payments. They are supported by these funds. And so I know we've had many discussions here about how much we're giving to treatment or not giving to treatment. Do we want to increase one versus the other? But I just want you all to think through that these areas have no other funding source but these that we are discussing. The other pillars, the other services, whatever clinical services being provided, we have this other funding that is even beyond Medicaid. And so just keep that in mind as you keep thinking how to allocate the funding in the upcoming years. And the last thing in terms of the HR1 question and impacts, most of the HR1 impacts from this administration, so the big, beautiful bill or the bad bill, depends on how you want to call it, has been from the policy and the reductions in terms of eligibility to federally funded programs, both through Medicaid, the SNAP program. Those are the long-lasting impacts. And then you do have, but those are, as I think someone was talking about, very hard to track the federal funding that is being eliminated because it's been a constant chaos, as many of you know, because they are canceled today, then people sue, the state sue the administration, they are reinstated, some are non-reinstated. And so that's been a dance, and it's very hard to predict, but that is a good source of information. But again, that could change, that gives forecasts for the federal government, what funding changes are in the proposed president's budget, but we also know that those don't necessarily end up being the budget. So just to say that that piece from a federal funding perspective, it's harder to forecast, but that the policy changes that do impact the budget of Medicaid and DHS, the SNAP program, the state benefit programs, those are much easier, and the impact, we do had the presentation, and we can come back as we continue to implement and develop mitigation plans. We can come back and present this to you.
Thanks so much, Assistant Secretary. That's a good segue into the next section. Actually, I'm just looking at the time and I want to move us along to the recommendation. Sure, go ahead, Paul. Yeah.
If we was to dig down into that restricted account, would we actually get a clear answer to the account itself, why it was created?
That our goal is to get a clear answer for you. Yeah, I think we have a question up for that green bucket. You have a question,
I
right?
already asked the OMB,
Yeah.
like clear, but I think that the assistant secretary sort of answered that it could be like, yeah, but do you want to?
Creation of that. And I understand what she's saying.
Yeah.
But what's the need of the restricted account?
Hmm.
To that?
Okay, what's the need? Yeah. We'll
All right,
get that
That's a different question, and I don't know if we'll be able to answer that question. Restricted accounts are always need authorization by the state legislators. A state does not make that on their own. We may request permission, but we need to be granted permission by the legislators to classify an account as a restricted account. And again, it doesn't mean that people don't have visibility into it. It just means the way it's accounted for in the state account listings where you have, it's like usually state general revenue, it's for example 01, federal is number 02, restricted is number 03. It's just a classification, and you do need permission from the General Assembly to create that kind of account in your levers and books.
Okay.
Every restricted account that exists in the state has a legislative authorization.
Trying to get as much information on this one as possible. Present it, loop back next month. Yeah. Okay. Okay, I'd like to move us into the recommendations now for fiscal year 2028. I'm going to introduce a few of the guidelines and frameworks that you've seen before, so I'm going to move through that quickly, and then Kathy will present to you the proposal for discussion. The data that you saw, particularly from the OMB report by pillar, informed to some degree what Kathy will be presenting and what we are recommending for fiscal year 20. So go to the next slide. So just very quickly, you've seen this all before. This is our set of guiding principles for you as a body in terms of decision making. They are from the Johns Hopkins document. The first 5 principles specifically come from that document. Several years ago, the committee voted to add a 6th principle around sustainability. So I will not read those out for you, but those are the principles there that the committee adopted to guide its recommendations process. For the next slide. So we also wanted to highlight the crucial importance of equity in these discussions. This is more important, I would argue, than ever. We've seen significant declines in overdose deaths in all population groups, but not all are benefiting equally. And if anything, the inequity in overdose deaths is growing. This last year at the task force last month, and I think Ben presented the data here in June, that overdose deaths among Black Rhode Islanders are twice that of white people in the States. So we're seeing significant and ongoing racial inequities in overdose, which continue to need to be a focus, I would argue. We have a Russia equity pillar, and then also integrate equity considerations at all stages of the recommendation, decision-making, and procurement process. So I just wanted to highlight that. I won't read out all of the boxes, but you can see here how the state operationalizes equity in its decision-making. Is there anything else you wanted to add on that piece, Kathy?
The only thing the procurement part of it is that we have boilerplate language, for our contracts. That includes specifically equity. And I learned actually from the assistant secretary when I asked her, how do you actually do that?
Yeah.
And it's about the way that you start to fund it and you evaluate, say an RFP that comes in, is you make sure that you have an equity measure in there for consideration when you're awarding funds. So.
And the last one I'll share and then hand it over to Kathy is my favorite, which is the continuum of care model. So we have adopted this model as well to help guide our allocation recommendations. So the idea here is to use the settlement monies to move Rhode Islanders through the continuum of care, right? We invest in social determinants. We know things like housing are absolutely critical to give people a foundation in the first place. We invest in harm reduction and rescue because we know it saves lives, but also because it serves as a bridge, right, along the continuum of care towards treatment and recovery. We invest in treatment and recovery resources to support people achieve recovery and maintain recovery throughout the life course. And of course, we have a prevention pillar, which supports all of the efforts and aims to reduce the number of people at risk for overdose and addiction in the first place. So that's the idea here, is to use the funding strategically to move people along the continuum of care. So those are the 3 high-level heuristics that I like to think about when we're talking through these recommendations. I'll hand it over to Kathy now to walk through what we are presenting for you for fiscal year 2028. Take it away, Kathy.
You can move to the next slide. So I'm going to go through these quickly, the first couple of slides, because this is just showing you the process. The whole of government governance structure, this is actually the structure that we use. So when I talk about how we get the recommendations from the Governor's Overdose Task Force, we then come here to you all and we present them to you. That's the community engagement piece. But then there's also looking at data, as that's one of the reasons why Dr. Schultz, it's actually Dr. Schultz, who I like to share that. She presented today is to really show you sort of higher level of what our performance is and if we're moving in the right direction. And then this is our core agency leadership. So we have different levels of governance. So I'm going to start from the bottom, actually. The core function convening is like emerging issues and planning. We meet across city agencies on a regular basis. And then we have the agency core teams. This is our programmatic fiscal evaluation and data. Michelle and I meet with each of the agencies, including the Department of Corrections, on a monthly basis. And we include fiscal and programs so that we go line for line across each of the different initiatives to see what the progress is and what the needs are. Interagency teams. This is level 2, where we talk a lot about strategy and planning. And we include our other agencies that may not necessarily be stewards of settlement, but it helps us with planning. And then finally, level 1, which is meeting with our agency directors. Next slide. And then here is the strategic approach that I had presented last year. And I just want to remind everybody, I kind of spoke about this as you were asking questions. That again, this is not done in a vacuum. And it's kind of like this is showing a little bit more detail with a timeline of all of the things I just said to you at a higher level. And I just want to sort of remind everybody that this is how we come up with these proposals. So the proposals are not Kathy just makes a timetable, a table with Michelle, and we say, let's just put these percentages. We literally take a lot of time. It takes us a couple of months of meeting with community partners, with the agencies, looking at contracts, looking at encumbered, looking at the budgets, looking at the spending to come up with these percentage proposals for you. Next slide, please. And here again is the funding recommendation process. So it's kind of like I'm trying to bring you through the timeline here. This gives you that, all of the things that we do. I also want to remind you all, and I say this because you all work really hard to do this. This isn't about me or even the state agencies, that we are nationally recognized for this. And sometimes people go to other national conferences and then they'll text me and say, hey, I'm here and Rhode Island's doing good. It's like, yeah, we're outreached all the time. Dr. Marshall is, I know I am, and I'm sure some of our agencies and some of our representatives on a regular basis because of the organizational process that we put together for these recommendations. Doesn't mean it's perfect, but it is all of you that made these decisions for policies and how we're going to move forward. And I think we're going to the main objective here. And I want to make sure that you all have enough time to discuss this because it's a lot of information today. And I also want to say that one of the reasons why we're presenting this to you now is because we want to give you time to consider this and then get your feedback, like Dr. Marshall said, and then next month will be the vote. So I can't see this at all without glasses. So as you can see here, what we really tried to do, our main focus was to talk to the agencies and look at the funding, like we said about like federal funding, the OMB report. And I got a couple of notes that I'm gonna like read off to you. And I'm not gonna go line for line, I'm just gonna read some high level. It was noted that treatment received a lot of funding in the beginning, and also as shown in the OMB report, most is Medicaid reimbursed. And it was also noted that the Rural Health Transformation Program also has specifically for recovery. I'm talking about these two pillars right now so that I can explain why those percentages are a little bit lower. Because when I met with the agencies and then we considered everything, the Rural Health Transformation also has specific funding for recovery centers in our rural communities. That RFP actually is out right now, and it ends on July 26th. So hopefully there is going to be some applications that come in, but that is going to be funded by federal funding, which is the Rural Health Transformation. And then if you look at that OMB report, you'll really see that a lot of the treatment, even the federal funding is a higher percentage than even recovery. So a lot of it is funded through other sources. In addition to that, Treatment, prevention, and harm reduction remain the same, with a slight decrease in social determinants of health based on recommendations and also based on when you look at the OMB report and also when we talk to our state agencies. And I think another thing that was brought up is the CCBHCs help to reduce some of the Medicaid costs because it's a higher reimbursement rate. And then, you know, I wanted to just kind of put some of those thoughts out there to you. And this information actually came from the agencies. This isn't Kathy's information. I went through this as we were preparing these proposals with BHTDH, the Department of Health, and our teams at AOHHS to kind of come up with these percentages. And I think the most important part is that if you look at this, the percentages haven't changed tremendously. It is the exact same amount of money as it was in 2027. So it's a little bit easier to look at than it was last year. Last year was like a very big difference. But they haven't changed that much, except they fluctuated a little bit in treatment and recovery based on spending and based on the need from the agencies that propose these recommendations.
And we have one more slide that shows these percentages in absolute dollars, if that's helpful. So we can get to that if you'd rather look at that one. Each percentage is 100,000. So that's another way that I like to think about it. Yes, thank you. So, okay. Maybe let's go back to the percentages for now, but we've got that slide available. Okay, should we open it up for discussion? Kathy, would love your feedback on what is being proposed. We're going to take that, make necessary changes, and then we'll present again with any more information you request before the vote in August. So the floor is yours, folks. Yes, Director.
You know what would help?
Yes, please.
If there's a way of somebody being not the community meetings that we had and all the suggestions that were made and the priorities, to what extent are any of them incorporated in? Can't incorporate them all. Some are sustained efforts of the past, but how did all those community meetings inform this particular allocation? So it's going to be drilling down maybe into the weeds as to what constitutes the 11% in treatment, but are we able to use that information to actually inform this allocation? And if so, in what way? I don't expect an answer now, but between now and the next meeting, that would then help me figure out, okay, what can we do and what can't we do with this allocation?
So the recommendations, we can send that out to you once again. But that was actually, our partners at Round actually put together a narrative and we passed that out at one of our former meetings or other meetings. And a lot, just to be clear, the recommendations were not focused on funding. They were focused on, some of it was you need to do more of this and you need to put more in this. A lot of it was actually policy. That's why Senator actually talked a lot about policy in that meeting, because he was talking about some of the legislation that was happening. And a lot of it had to do with policies. It had to do with stigma. Like emerging issues was there, drug checking. But so to your question, if drug checking, what pillar would that fit in? That would be more of a strategic planning conversation. I know where it would fit and where the funding would be. It would be in harm reduction because that's where it belongs, right? So that's it, or it could be emerging issues. So that kind of detailed information happens more on a state level as far as building out programs. But we can send that to you.
To the extent those recommendations were made, are they reflected in?
Yeah.
So
all the decisions are made.
Or in harm reduction, are we doing more in harm reduction? In what way? By allocating funds in that.
I think it said to sustain harm reduction because of federal funding. If I remember many of
whatever it said.
Yeah, the themes.
Yeah.
General question. So one thing over the course of the years that we've discussed is as we've seen progress in some of our high level metrics like decrease in fatal overdose, whether or not we should shift more into prevention. So I just want to bring that to this group. So we're at a point where we've seen more than a 50% decrease, right, in fatal overdose deaths. We want to start thinking about a little bit more prevention. Not sure where that money is going to come from, because I agree with all these categories, but I want to kind of throw it out to the group. It's one thing we had talked over the years, that as we see some of these shifts, that we'll probably invest a little bit more in prevention over time. So I just want to bring that up as a discussion.
And I agree. Don't in no way disagree. I am going to say that I'm going to say this from Chris's presentation and being very much at a community level across all the agencies, whatever we're doing is working. And to shift, I wonder for the committee to consider to shift funding significantly into another area now. I don't know. That's for you all to think about. And then to consider the presentation from the OMB. I think it was 90% was federal funding for prevention right now. So just to please add to that, because I know when you actually were on the committee, you had made some points a few years ago.
Yeah, that's, when we show that slide of the funding source by pillar, you see so much federal funding for prevention. And I wish we knew more that was going to continue or maybe increase, but it sounds like we don't. With this administration, we don't know. But nonetheless, the data suggests that to date, there's significant funding, federal funding available for prevention efforts. So I agree with Kathy, I'd point to that. Although great point, Dr. Chan, and again, other committee members, please weigh in because this is an area where there might be debate and possible disagreement. Yeah. Dr. McAdoo, do you have a comment on that? Okay.
So first, I just want to say kudos and fabulous work. I know that creating these percentages takes a tremendous amount of time and effort and talking and consulting a ton of people. So I guess I have more of a question, I guess in light of the dear colleague that we're speaking to and all of the other assaults on harm reduction that's coming from the federal level, I guess I would have expected that the need for that category that years and later. But I see that over time it's maintained, it's remained fairly stagnant, from 26% to fiscal year 2026. I was curious if you could talk about why we didn't have a greater allocation to that category in light of those federal changes.
For harm reduction. Well, because it would take from another pillar is the best answer I can give to you. That's really it in a nutshell. It would literally take from another pillar. Because you can't be more than 100% of the children. I am going to say that we did increase social determinants of health a little bit because that was actually a recommendation, many of the recommendations that came out of that, and that was addressing the most basic needs. Actually, this committee as well, Mr. O'Neill over there actually talked very much about, when you're hungry, it's really hard to enter into recovery or if you don't have a roof over your head and a safe place to live.
We had a request from the chat. They couldn't hear the question.
Oh, great. Yeah, I can summarize if that's helpful, Karen. Dr. McAdoo asked, given the changes to the federal funding landscape for harm reduction, why wouldn't that pillar be proportionately higher with respect to what's proposed? Could folks hear the answer that Kathy gave here, Karen?
Sure, you can hear me.
Yeah, hopefully folks can hear Kathy. Let us know if you can. Yeah, Julia.
I have a related question, and I appreciate, Kathy, the point you're making of if to allocate money to one category is to take it from another. I guess I'm interested, we've allocated different amounts each year. We're being asked to allocate 10 million this year. I think it might just be helpful to understand what's the foundation for the 10 million amount as opposed to some other amount.
It's the estimated payments coming the year, based on our opioid payment schedule.
So we estimate 10 million will come in fiscal 2028. So that's what we know is available in hand to allocate next month for fiscal year 2028. Does that make sense?
If you look at
Yeah, no, it does. I totally understand that. I guess I'm just curious because, we've talked about how the money comes in when it comes in for the settlement. That isn't based on need, that's just based on the settlement
Yeah.
terms. And so I guess ask the question, not with any value judgment in any direction, just curious, like if, because we don't have to allocate it all in a certain year, like if there is a need for 10 million, if like there's something else hitting that.
Oh,
Question, is there a need for the 10 million?
There's a need for all of the money, but my
Oh,
question just being of why 10 million this year as opposed to some other amount, but
Oh, well.
it seems like it's just based on what's coming in.
So based on the conversations with the agencies and spending, if you go back to spending, we spent, it was 13.7 million in FY 26, right? And that's not even totaled yet.
Sure.
That's why we're anticipating just allocating all of the revenue that's coming in, because if we didn't, then that could result in not being able to meet some of the obligations that we already have with existing contracts and also sort of keeping our infrastructure solid. The other thing I want to note too is, and I'm sorry, I didn't note this on the last column, not only I went through this again, and I went through this with the agencies to just make sure that they agreed. So in the middle, you have the strategies and programs. That gives just a brief description of like what that is. It didn't change much. It changed a little bit just based on some of the agency feedback. But on the other end is, if you notice, you all decided and have said that you want to focus on sustaining and also the infrastructure. There are certain infrastructure funds in here to be able to either administer, evaluate, have the surveillance data that's needed to be able to continue to do the work we're doing. And then also, you see like harm reduction, prevention for sustainment. That was another really important consideration when the agencies and also the community gave input, is to sustain our infrastructures. For instance, naloxone distribution. Naloxone distribution is fully funded by settlement, and I believe maybe a little bit stewardship. I think it's fully funded by settlement. So that is our partnership with URI. That is where they accept all the free Teva kits, and then they come up with a distribution plan. So that's part of the infrastructure to be able to get naloxone across the state and meet the goal that we have to pass it out using the profound model public research.
so that's your question, Julia. And we don't ask you to allocate more than what we know is already in hand, right? So just to, we don't have the Purdue settlement yet, so we're not going to ask you to allocate that funding because we don't know the details of those amounts. So that does that answer your question about why 10 million?
Yeah.
In either direction, lower or higher?
Yeah, I think so.
Yes.
Okay, so, and again, thank you for the work on this. I understand, my least favorite time of year is budget time, which
And
seems
it's
to be
in the
all the
summer.
time, so I get it, and I appreciate the work. I did want to clarify, so I have a few points. Evaluation and data. I absolutely understand and support the need for both of those things, and we're always asking you for more and more data, so I get it. But 6% to 8%, $800,000, that, I'd like to know a little more about what is kind of leading us in that direction, especially where, we're splitting percentages and we're trying to, allocate appropriately amongst the pillars. What is the basis for the 3% increase across those two? So that's one question I had. I agree with Dr. McAdoo's point about the harm reduction. My assumption was that we would be kind of leaning hard into that category because we know the feds are going to stay on this course of denying funding for that type of activity. So that's a thought. And then the other thing, social determinants of health, I do appreciate that that's increased. However, as the two slides before, when we're talking about, and Dr. Marshall, when you made the point about the racial disparities that we're still seeing, and the slide that indicated that these disparities are driven by structural racism and other historical and structural systems of oppression, it seems to me that the social determinants of health could be a category where we could address some of that. as opposed to just looking at the racial equity. If we're talking about structures and systems, then maybe those social determinants is where we can really do some good work in addressing those racial disparities. But that's really disappointing to hear. I mean, as all the good work that's gone on, that we're not really getting at the heart of that particular issue. So just some thoughts there. And if we were able to kind of shave off some percentage points from the other categories, that maybe that the harm reduction, social determinants are where I would suggest from where I'm sitting right now that we maybe add in. So.
Super helpful. Reactions to Julie's comments or others? Go back to Dr. Chan's point about prevention being a focus in this era of declining overdose rates. Yes.
I would just echo. So I mean, I think the two things that really stood out over the last couple of months is the work on harm reduction. So being cognizant that there's not necessarily the federal backroom there, just stay mindful of it. Two, the other thing that sticks out for all the success we've had with harm reduction, it seems like, and non-fatal overdose overall, for reasons that have been documented, and probably other ones that still need further research, we have not had the same success when it comes to communities of color historically.
Yeah. Thank you. Yes, Chief.
Yep, I'm in agreement as well. Julie said it.
Hey, sorry.
Do you strongly disagree?
Actually, I just wanted to flag a minor potential error. I was looking at, numbers for evaluation, going from 3% to 4%. And then comparing that to the absolute numbers, both are $350,000. So I was curious if, I guess I would expect to see an increase in the absolute number as well.
Yeah, it might be, I either missed it or it's because when I did the calculation, did I ask you to check that slide? I need Michelle to check the numbers, so thank you for that.
Yeah,
I
that's
will
helpful.
take
I
that.
was looking at it, I'm like, oh, that's,
Okay.
you know.
It also is the
33%.
rounding too,
Yeah.
because it has to come to 100, so.
Yeah.
We'll
We'll
take.
correct that. Yeah, right. Others? Yeah, Director, and then Mike.
The prevention pillar. Follow up on Dr. Chan's comments. What those funds are being allocated for.
Yeah.
And are there any that will go into the area of any cannabis use for adolescents?
So I can answer that question. I can also answer the racial equity and give you very specific programs because those are just happen to be the two that are only to one program. So it was actually BHTDH who asked for $1.2 million specifically to fund the Rhode Island Student Assistance Program. So that was the only thing. That's $1.2 million. That's exactly the amount of that. So that's the answer to that.
So there's no other funding?
No, not for cannabis. The 1.2 was the request. So I go to each respective agency who has statutory authority. And that was what came from BHTDH was to ask for the 1.2 million for Rhode Island student assistance. Now, I don't know if within the program they're doing cannabis.
If we had asked for more, we would have got that.
Then it would have impacted all the other ones. So I don't know about that. Like we just said, and we, as you can see, that has stayed steady at 12% across. And I also think that it's about spending too, which I want to give kudos. BHDDH is very mindful to not, to think about what they can spend and can't spend because you have a lot of SOAR and block grant money as well. That's funding those programs. And then the same with racial equity. That request specifically for racial equity was actually for the program at the Department of Health. That is not, it is addressing specifically, and it's led by people who are directly impacted. And it's what we called a BIPOC program specifically. So it's doing, a different, it is specifically for sort of addressing, stigma and a place for people to kind of be together and specific targeted outreach to. So.
I'll respond as well, Director. I know we had a presentation from RISAS, the Student Assistance Program. We can pull up those slides and recirculate them. If I recall, there is braided federal funding.
Yes.
But the settlement funding was used to add, I think, more modules on prevention of opioid use and, but I can't recall about cannabis, but so they did, I think they used settlement funding to expand the purview of that program to focus on substance use. I just can't remember what type of substance use, but that's my recollection. Yeah.
Rather than really specific on a prevention program to the adolescent.
So.
Yeah.
One of the things that I also want to point out is that for the prevention, not in this fiscal year, but originally we actually had funded a lot of funding to the prevention pillar. And part of it was the Rhode Island Student Assistance Counselors, but there was also a pretty large bucket of money that was allocated for community prevention. And that is actually the program that is rated with other funding too, like recovery and stuff. That is that partnership with Rhode Island Foundation. We actively have contracts with some people that might be in this room and their organizations through that Rhode Island Foundation pot of money. And we, again, I prefer, and I think organizations have told us through recommendations, they prefer multi-year contracts. So we're only in year one of that third round of that Rhode Island Foundation grant, and we have one full year coming. We also have some of our code projects that are funded through the community prevention funds as well. So they're still out in the community being spent.
Yeah, that's a great point, Kathy. So if I recall, that was that non-school-based community prevention was allocated, I think, in 2023 or 2024.
Yeah, and it was a pretty.
So you're saying that money was allocated then and is still going out the door today?
Yes.
Yeah. And for the purposes of not making this slide too busy, we truncated at 2025 allocations. If it's helpful, we can give you even more of a look back, which we'll see that large prevention investment early on in the settlement.
And that's not as hard as the encumbered.
No, that's an easy one. We will get you the encumbered. All right, but that's an easy one. Yes, Mike, thank you.
Yes,
There was one.
thank you. I just wanted to speak to the prevention component here. As I'm the director, I oversee the Jim Gillett Teen Center. And so to many people's conversations, the cannabis and youth, it's something that's really up there every day, very, very much in their face. And some of the feedback that I get from the children or the youth are that they don't receive services that are people, if they went to a recovery house, in other words, or they went to a treatment, it would be all old people around them.
Right.
And kind of comical, but it's true. So, when I think about recovery housing for youth, I think that's something that would be really helpful. I know that the teen center wouldn't be able to survive or provide the services we do without Rhode Island Foundation and without some other grants that we get from, different folks in the community. It's a struggle every day to keep the doors open, honestly.
The Teen Center is actually one of the funded organizations.
Yeah,
The
Rhode Island Foundation, yeah. Yeah, they give us money, so.
Okay. Any other feedback for us before we move into public comment? Yes. Yeah.
This is just sort of like a final thought that it may not even be actionable for this year, but it's just been taking different parts of the conversation. And, I think one thing we've talked a few times about, and it's not yet imminent, is the Purdue payment will be coming, which is a large amount.
Yeah.
And, I think it sounds like we're balancing a lot of considerations. There's the need for continuity of guarantee of funding for our community partners. There's obviously urgent need every day to fund these things. And there's also the issue of sustainability that we've talked about a few times. And so I think that one thing that comes to mind is that there may need to be more, and there's also carry forward. So we're also seeing that funds are rolling over, are being spent in future years. And so it just sort of, for me, raises the question of in future years, how do we think about the amount that we're allocating each year and sort of being thoughtful about that, trying to balance all those different interests. So something to think about for future discussions.
Michelle would love. We just don't want to know every year.
It would.
And that will become particularly important with Purdue, right, where we will have more flexibility. You as a committee can decide how and when you allocate the Purdue funding because it's coming all up front. We don't have a lot of update for you on the Purdue piece, although Kathy and I have been meeting with national state partners. We're learning more about what is and is not feasible and want to have that discussion as soon as we have concrete answers for you. We don't want to offer proposals that turn out not to be legal or workable. So, but please know that those discussions are happening. We are learning more, I would say, Kathy. So, and as far as I'm aware, we have no specific date, right, Julia?
That's right.
When this Purdue settlement's coming in, so no urgency, but we're trying to stay on it. Yes.
And just so we don't forget, Dr. Chan brought up an interesting thing about a year ago for sustainability and what the big chunk of cash that's coming in here to keep us going. This is not going anywhere.
That's right.
We gotta think that this has to keep going for the benefit of the people that we serve. Because we got an opportunity that's coming up with the money so that this stays together.
Yeah.
And I believe Dr. Chan had a great idea that we all should be looking at when the money actually.
Yeah.
Yeah.
I would agree, but I would also remind you that the money goes down. So that it just, and I think what's great is that, not great, but I'm not just trying to say, let's push this. It's, the truth is, in October, we already agreed that we're gonna really have a conversation about what to do with Purdue and have some policies in place. And we definitely revisit that.
Okay.
And, you know, you'll have a couple of months off after, if we can come to a vote next month. Just saying.
Just so we don't forget.
Yes.
Saying.
Yes.
And then, you'll have, you know, a month or so off and maybe we can all kind of group in October. And Mike's gonna run the show and tell us all what to do.
But couldn't agree with you more, Rep. Hall. This is an intergenerational problem, right? There's people directly impacted out there today, and then families, children, and so on and so on. So this is with us for many years. Okay, I'm going to move us into the final public comment, but what I might do is just summarize some of the recommendations and feedback. And please let me know if I missed anything. So there was a request to have obligated and unobligated amounts by pillar. More detail behind the proposed 8% allocation for the data pillar. Mapping of community recommendations onto these pillars and recommendations. A request to reconsider the harm reduction, rescue, and social determinants of health allocations, given the exposure or risk of lack of federal funding on those domains, so we can take that feedback. And then also thinking more broadly, I really liked your point, Julie, about addressing structural racism in the context of the social determinants of health. So those are some of the main points that I took from today's discussion. Please let me know now or afterwards if I missed any or you'd like to share some privately, and we'll prepare all of this for you at the August meeting in advance of the vote. Okay, so let's move into our final public comment period. We can start with in the room. If there's any comment from members of the public, the floor is yours. Seems like we may have more folks on Zoom or Teams today, so I will give it a moment there for anyone. Feel free to unmute yourself if you have a question or a comment for the committee to consider.
There's only 18 people.
Okay. So we'll move into the last part of the meeting, just a few final updates. I went through most of my updates. That was a placeholder for me to remind you about the Purdue settlement, so I did that already. And over to you, Kathy, for the task force updates.
Hey,
Close this out. Yeah.
so last month, we actually, that was what Christina, Dr. Schultz was saying. The Department of Health actually presented the overdose surveillance system and some of the changes. They are now looking at all substances. So that's going to impact the Overdose Data Council metrics because we were looking at non-fatal opioid-related overdoses, but if they're looking at all substances, which would be more equitable anyway, we will be revisiting that. Cobre provided a presentation on community drug checking, very timely to the point of Director Leclerc asked about the recommendations and really looking at those recommendations and seeing how they've been incorporated in our proposals. Yes, and a lot of them were also policies. Drug checking was one of them that we've been hearing, but we heard a lot about that because of the changing drug supply. Legislative updates from Senator Vasilian and Senator Imperatus, I can't say it, Miller, somebody else named Senator Miller that name, by the way, and it's beautiful, it's perfect. And then access, you can access these presentations at the presentation archive, which is on Prevent Overdose RI, so that's still the central place. The next overdose task force is August 12th. It is going to be virtual, and the topic is going to be harm reduction rescue focus for the 25th anniversary of International Overdose Awareness Day. So we have a couple of different presentations, but they're going to be focused on like naloxone, some qualitative studies. We also are asking a partner to present for us a naloxone temple, I think we've asked, and I think that's on deck to be presented, as well as another qualitative data. And and also a reminder, next slide please, that this is, we are going into August now, and this is where we sort of kick off Recovery Month with International Overdose Awareness Day. This is an opportunity for us all and anybody who's been impacted by overdose to celebrate the lives of people who have been impacted. And also the community comes together, celebrates each other, but also does a massive naloxone distribution, which usually is about 5,000 kits of naloxone all over the state. They're at stores, they're at CVS's, Stop and Shops, all over the state from Woonsocket to Westerly, passing out naloxone. And then Rally for Recovery. September is Recovery Month. And the main rally will be held on September 19th at 195 District Park. There's also rallies across the state. Well, I will keep you all informed as I get those dates. And you know, I know Mike might know some of the dates too, other ones. There's going to be Warren usually, and across the state we have rallies. So
You are right.
celebrate.
After,
You all right?
yeah, have them in South County.
Are they?
Yeah, week after the main rally.
All right, cool. So once we get more information, there's also a QR code for the event information that will bring you right to the Prevent Overdose RI webpage.
Thanks, Kathy. So thank you all. Our next meeting is in August. This is a big one. We vote on the 2020 recommendations. Please email me if you have any other feedback for things you'd like to see in advance of that meeting. I'm very grateful for all of your feedback today. This has been a very rich discussion. Continually blown away with everything you bring to this meeting and dedication you bring to helping all Rhode Islanders across our state. So to that, I will ask for a motion to adjourn.
So moved.
So moved. For a second, all in favor?
Aye.
Any opposed? Abstained? All right, thanks.
I'm not.
We'll see you in August. Take care.